Hello, everyone. This is Dr. Vishal Gewali from Queen's University, Kingston, Canada. Today, I wanted to talk about at least 10 fundamental health literacy principles that I believe are quite important for the patient and the public and the whole community at large to understand when reading a media report on any new journal articles or any new research findings with regards to health. And I think these are some fundamental principles that are important for everyone to understand, because sometimes I see that people get confused, or even the media headlines are misleading and are different from what the actual report is telling, or what the research findings say. So what are those 10 principles that I want to talk about today? First, as a patient or as a member of the public, if you're reading about any new finding, any new research finding, let's say there is a finding that says this new blockbuster drug improves lives for patients with breast cancer. There is a new blockbuster drug in prostate cancer that is going to change the way we treat this disease. A new miracle drug in pancreatic cancer is going to save lives, or whatever. So when you're reading such news article, or the journal article, then the first thing you need to ask is, what are they measuring in the trial or in the study? What is it that they're measuring, and does that matter to me? Because sometimes these trials are measuring whether people live longer on these treatments compared to not getting these treatments, which is a meaningful metric. Do I live longer if I get this drug? Or do I live better if I get this drug, which is measured as quality of life in these trials. But sometimes these trials are not measuring this and measuring something else. For example, does the tumor shrink by a couple of millimeters? Does the tumor shrink by 30% when I get this drug? Or does it delay the time until the tumor grows by a certain metric? Does it delay the time until the tumor comes back after getting primarily treated? So there are different things a trial can measure. Showing that a drug improves the length of life or the quality of life is difficult and is an important metric. It's far more easier for the drugs to show that they shrink the tumor by a small margin, which may not translate to longer or better lives. So the first question we need to ask is, what is it that the trial is measuring? And whatever the trial is measuring, is it meaningful to me? The second thing is to understand that, dying with a disease is not the same as dying from the disease. And this is important, especially when we are thinking about screening for any health condition. So in oncology, let's talk about thyroid cancer. There has been huge increase in the frequency of thyroid cancers in recent years in several parts of the world. But the mortality from thyroid cancer has remained nearly stagnant. Why is that? Because we are diagnosing more and more cancers that are actually not lethal. We are just diagnosing more. These cancers were not going to kill people in the first place. That is what we refer to as overdiagnosis. So we may be detecting more cancers, but those cancers may not be the lethal ones that are going to kill the person. So we have to ask whether or not these are lethal, whether or not these are going to impact on the length of life. So a person may be diagnosed with a cancer, but if it is not affecting their life, then they will die their natural death at some time point, but they would still be called that, okay, they had this type of cancer. So dying with a cancer and dying from a cancer are different things. So that is the reason why we usually don't recommend screening for patients with who already have metastatic cancer, for example. I see some patients, who have advanced gallbladder cancer, and the average survival in advanced gallbladder cancer is less than a year. The median survival is less than a year. But even these patients who have advanced gallbladder cancer and are getting treated for that, I see some of them are still undergoing mammogram screening or some other type of screening. But that's a lack of understanding that even if that new screening test led to a new diagnosis of cancer, probably that cancer is not going to be lethal for the patient who already has an advanced gallbladder cancer to begin with, which is a far more lethal cancer, N is the more likely cause of death. So if someone already has advanced or metastatic lethal cancer, there is no point in undergoing screening for some other cancers. Third point I want to talk about is about value judgment. Different people, they will have different values. Different people will view different metrics differently. For some patient, extra survival of 3 months might be supremely important, worth all the side effects and the cost. But there might be some people who might not even value 1 year of extra survival, um, even if there is not much toxicities from the treatment. So we have to accept that different people will look at the same number, the same metric, and will come up with different value judgments. However, important to understand that there are hidden costs of treatment. There are hidden of undergoing treatment, such as time it requires. It's not only about the money, but it's also about the time commitment or the burden on life and daily activities of life that might have factored into the decision making. So just to mention that the people might look at the same numbers, same benefits, same side effects, same cost, but come up with different decisions for the given condition. And fourth, which should not come as a surprise, is there are always uncertainties in medicine. Many times we, especially who are in the field of practicing medicine, like doctors and researchers, we try to pretend that we know things when in fact we don't. A question as simple as, how long am I going to live, doctor? From a patient with cancer, this is the commonest question that we get. How long am I going to live? How much benefit is this treatment going to offer? And to be honest, we don't know the answer to these questions most of the times. We can come up with medians from data that we have seen in trials or from real world evidence. And the median, by definition, means half of the patients will do better than what we say, half of the patients will do worse than what we say. We can provide a range. This might be the worst case scenario, this might be the best case scenario, and we might offer the midpoint. But we are never going to be able to answer precisely that question for a given person in a given situation. So as a patient, you should, I think, rather than asking the midpoint, I think you should ask for a range of options. What is my best case scenario and what is my worst case scenario? And try to, and what is the most common scenario? And try to make a judgment based on answer to those questions. We are never like, there are always going to be uncertainties in medicine. Even a question as simple as okay, if I take this drug, am I going to live longer, or how much benefit is this drug going to offer me? There will be uncertainties in answering even those simple questions. And the fifth is the plural of anecdotes is not data. So in oncology, especially, we get so persuaded by emotional stories because there are people who are telling these stories and there are emotions attached to it. Especially there is so much influence of celebrities. We see a celebrity who underwent a prostate cancer screening test, got prostate cancer detected, and underwent surgery or whatever intervention for that. And now that celebrity feels that it's his duty to inform the public about the value of prostate cancer screening. However, the problem with such emotional stories is that that particular person feels that his or her life was saved because of that intervention, when in fact it may not have been the case. In fact, it might have been a cancer that might not have been lethal, as we discussed in point number 2, that it could be dying with the cancer versus dying from the cancer. The cancer may not have been important to detect. It might have been overdiagnosis. There might be some complications of the treatment. However, it's not a happy feeling for anyone to think that someone underwent all that intervention in vain and that they could have avoided. And it's also a humanistic feeling to think that, oh, I want to save other people. I'm glad that my cancer got detected early. I want other people to have the cancer detected early, without knowing the fact that maybe that cancer was not even worth detecting early in the first place, because it might not have progressed in that person's lifespan. And the other fact is that most of the people who undergo such interventions and suffer the harms of the interventions, they do not have as much motivation to come and speak about their experiences as much as people who think they have been saved and want to save other people. So many people undergo several interventions that are futile or might be harmful, but they do not have the motivation to come up to media and share their experiences. So we need to keep that in mind, especially when we are hearing case stories, one person, two-person. Sometimes we hear about these drugs that we know are pretty toxic and not meaningful, but we often hear like there will be one patient or two people who will say that, okay, this drug saved my life. But the thing is, there will be several other hundreds of patients who suffered side effects from the drugs, did not have their life improved in any way, but who are not there to share their stories because they passed away, or because the drug didn't help them, or because they did not have the motivation to do that. Sixth point is, as a patient, when you are in the doctor's office and you are being offered any treatment, you should always ask, what is the alternative? What happens if I don't do this? What happens if I do this? And what is the alternative? These what if questions. What if, let's say, someone recommends you drug X? What if I don't take drug X? What would happen in a counterfactual world where people do not take this intervention? And actually, that leads us to our number 7, because those type of questions are answered with a randomized trial. Randomized trial is one of the biggest inventions in medicine. Randomized trials will help us answer these what if questions, the counterfactual world hypothetical scenario. What if I do not take this intervention? What if I do not take this drug? Those questions are answered by randomized trials. So in randomized trials, they randomly allocate half of the patients usually to new intervention or drug X, and half of the patients to receive that intervention or to receive the existing standard of care. And then they look at the outcomes and they look at the differences in outcomes. And because of that random allocation, depending on some statistical principles, we can be confident that whatever the results that we are seeing are not from chance, hopefully, and are a result of that intervention. So that's how we answer these what if questions. So if you are being recommended any treatment, you can ask, was this tested in a randomized trial? And what happened to the people who did not get this intervention? How much of a difference was there? And, number 8 is the difference between statistical significant and clinical meaningfulness. Because in many of these studies, what they look at is the statistical probability that the results are not from chance, but are from the interventions that we did. However, the results may not be from chance, but the results might be meaningless. For example, in oncology, we have seen drugs that improve survival by 10 days only, but it was statistically significant. What that means is that difference in 10 days is probably real. It's a real difference. But is it meaningful? It's 10 days of extra survival meaningful for the given side effects and the hassle of treatment and everything? So there comes the value judgment. But just to point out that a trial or a study may be positive, may be significant based on statistics, but it may not be positive or significant based on the clinical utility of the findings. Other point, number 9, is we need to watch both relative and absolute risks. Many times in media, in articles, they say this new cancer treatment reduces the risk of dying by 50%. This new intervention reduces your risk of getting cancer by 20%. You see these studies about nutritional science so often. Coffee reduces the risk of mortality by 1/3, or sometimes coffee increases the risk of mortality by 1/3. So whenever you are watching these risks by a certain person, there are two ways they may be expressing that. One is the absolute risk, the other is the relative risk. So let's say the baseline risk of dying is only 5%. The risks of dying with this new drug. Okay, let's for the sake of simplicity, let's say the baseline risk of dying is 1%, and with the use of this new drug, the risk of dying becomes 2% or 0.5%. So the risk of dying if you don't take this new intervention is 1% baseline. After taking this intervention, the risk of dying is 0.5%. So how much did the risk reduce? In relative terms, you can say that the risk has reduced by half, like 50%, from 1 to only 0.5. But in absolute terms, it's just 0.5% difference. 1 minus 0.5 is 0.5. So you could say the risk has decreased by 0.5% in absolute terms, or by 50% in relative terms. If you say 50%, it sounds sensational. Wow, the risk has reduced by 50%, half the risk, which is true. But in absolute terms, it's only 0.5% of the people, less people who would be dying, is what it is saying. So is that 0.5% meaningful? Now, again, you have to make a judgment, but do not be misled by the statement that the risk has reduced by 50%. Final point is, and this is something that we try to hint at in our discussion about value judgment, is that the individual level decision and the population level decision may not always align. And I think this is something that many people do not understand clearly. At a population level, let's say at a government level, there need to be certain decisions that has to be made for proper allocation of resources. But at an individual level, it's entirely up to the patient to make a judgment call, a value call. For example, there was this recent colonoscopy trial from the Nordic countries, which showed that inviting people to undergo colonoscopy as a screening test for colon cancer does not reduce mortality from the disease. And it was a little controversial, but I think it was controversial because people did not understand these differences between individual level decisions and population level decisions. Because at a population level, the country needs to decide, should I invest whatever limited resources that we have in inviting people to undergo colonoscopy? And the answer they saw was no, probably it's not very helpful. But at an individual level, should I or should this person undergo colonoscopy screening for detection of colon cancer? That depends on that person, his or her physician, the value judgment that they put, and the risk tolerance, and so many other factors. But at a population level, at a health system level, the health systems will need to make decision to not fund certain drugs, to not reimburse certain drugs, because on average, the benefit from these drugs are quite small compared to the high cost that they are charging. But there might be some patients who would think that even 10 days of survival is important for me, and I'm willing to pay $20,000 a month for that. That is an individual decision, individual call. But one cannot expect the health system to say that 10 days of survival gain is important enough for us to pay $20,000 a month and tax the taxpayers for that. So it is a sensitive issue, but there is no right and wrong answers here. But the fundamental premise is that at a population level, health systems will necessarily need to make a judgment call and will necessarily need to draw a line somewhere. That line might be different for different countries. But at an individual level, it's a different decision. So I think these 10 principles of health literacy that we discussed today, I think these are important for all of us to understand. Hopefully this video has been helpful for you. Thank you.